Okay, so I've been asked to speak about double level osteotomy, and it is a complex topic. And whatever possible, what are the tips and tricks that I've learned over the years, I will try to simplify this enigma. This is my profile. I practice as a dedicated arthroscopy, complex knee and shoulder surgeon in Mumbai. So the first thing that needs to come to your mind when you see this sort of a varus in a patient is that the deformity is severe. These patients are the ones where you would obviously get the scanogram done, and the scanogram typically will show a significant mechanical axis deviation. Most of these patients obviously have a significant ligamentous laxity, that is a varus thrust which is there when they walk. And their mechanical axis typically passes from outside the joint line. So that is the first pointer which should tell you that this is not a regular case for osteotomy. This is not a regular varus knee. This is not a regular medial compartment osteoarthritis knee. So clinical appearance of significant varus and mechanical axis which is passing outside the knee. The second important criterion is when you measure the angle. So you've got your scanogram done and now you've done your measurements. And in these cases where the mechanical axis is actually going practically through the edge of the medial tibial plateau, also you need to think in terms of a double osteotomy. So in this patient, we then go ahead, we know that the mechanical axis is passing medial to, just at the edge of the medial tibial plateau. We then go with the angles. So what are the important angles? We look for the LDFA, we look for the MPTA, we look for the femorotibial axis, the mechanical femorotibial axis. So if you find that the LDFA is anything beyond 90 to 93 degrees, it should be a pointer that you cannot do the entire correction on the tibia. Otherwise, you're going to change the joint line obliquity. So an LDFA, which is beyond 90 to 93 degrees, a mechanical axis which is passing through the edge of the medial tibial plateau is another indicator where you need to know that this is a double level correction. Obviously, when there is significant joint line laxity, there is going to be an increase in the joint line congruence angle. So this patient, for example, has got significant varus. There's almost a 17-degree varus. There's a joint line congruence angle of about 9 degree. All this, the joint line congruence laxity also has to be accounted into your correction. So these are the cases which should be pointers that this is not a straightforward high tibial osteotomy case. This is the Bible for all of you who are in the beginning of your practice to start reading about osteotomies around the knee. And very clearly mentioned in this book is that not all deformities of varus are in the tibia. In fact, only 31% of the deformities are in the tibia. About 10% are both in femur and tibia. And about 50% or so are actually also in the femur. So if you talk about osteotomies, it is the Hanover group which has said that 20% of their osteotomies for varus knee actually involve the distal femur. So almost always, these are the cases which we mentioned are having significant mechanical axis deviation, or they are LDFAs or on the higher side. So about 20% of the osteotomies in this German group is actually involving the femur. So what happens if you overcorrect the entire deformity on the tibia? So you need to understand the concept of joint line obliquity. As we know, the joint line obliquity is directed towards the medial side. That's how it normally is. In this patient, as you can see, there's a high lateral distal femoral angle. So if you do the entire correction on the tibia, you're going to land up shifting the mechanical axis, but in the process changing the joint line obliquity, in the process worsening your patient. Another example, typically this was done in the initial practices where we thought the entire correction can be done on the tibia. Massive corrections like anything above 15 degree should always point out to you that the MPTA is now going to go way beyond the normal of 90, like in this case, where a 15-degree correction was done with significant opening of about 20 millimeters. The MPTA went all the way up to 100 degree, changing the joint line obliquity completely. So there is no role for entire correction on the tibia and allowing the MPTA to go anything beyond 92 or 93 degrees on the higher side. So these are my take-home messages. So typically, this is how a double osteotomy planning will look, wherein you divide your deformity correction in the femur and the tibia. So a typical, say, about 13 or 14 degree varus in this patient has been divided with 7 degree in the femur and 6 degree in the tibia, such that the LDFA and the MPTA come into the normal ranges. I'll just discuss a few points in detail as to how you plan these cases in a simplified manner. Before that, just a quick revision. All of us know, where do you get your osteotomy line? Where do you get your mechanical axis to? We do not go to the Fujisawa point anymore. We go up to the 50 or the 55% line, which typically falls in the upslope of the medial tibial spine area or in the center of the knee, unless there is significant posterolateral complex laxity or a significant bipolar chondral loss on the medial compartment, in which you would look at the 55 or 60% point. So this is our patient again, who has an LDFA of 95 degrees. He has a varus of about 14 degrees. His MPTA is about 84 degrees. You cannot do the traditional Miniachi planning in these patients. As we know, the traditional Miniachi planning involves identifying the hinge point, getting your mechanical axis to the desired point, drawing lines from the hinge point to this new desired line, measuring that angle and translating that angle on either the tibia or the femur to get your corrections. However, this cannot be applied here because you're doing a double level correction. So simply, first thing you need to do is account for the joint line congruous angle. If it is anything beyond 2 degrees, so let us say it is about 9 degrees in this case, or if it is about 5 degrees in any case, you add 2 and divide by 2. So that amount of correction has to be divided from your total correction. So in this case, it is 9 degrees. So 9 plus 2, 11 divided by 2. So about 5 to 6 degrees should be deducted from your total correction. That's the first thing you need to do. If you are planning a double level osteotomy, you should target doing all this planning on a digital software like TraumaCAD, because that's the only way where you can dynamically do both the corrections. So you can do the medial opening wedge osteotomy and the distal femoral osteotomy and play with your mechanical axis. However, if it's not easily available, take a printout of your scanogram. As you see here, the mechanical axis is beyond the knee joint. You can divide your correction such that the deformity is divided between the femur and the tibia. Your LDFA, let us say in this case, was about 95 degrees. You're planning to get it to around 89 degrees. So you can do your 6 millimeter wedge and then just cut it like how you do traditionally. You just cut the correction to make sure that with doing this, the mechanical axis actually come into the medial joint line. The best thing about double level osteotomy is if you do your correction properly on the femur, you can always titrate it on the tibia to account for the 1 or 2 degree correction that you want to achieve. So coming back to this patient, I first planned a lateral closing wedge osteotomy. So that's the first thing you're going to do. So you get his LDFA from 95 degree to 89 degree by I planned a 7 mm wedge, and then go ahead with the medial opening wedge osteotomy such that the MPTA is increased from the pre-existent 85, 86 degree to about 90 degree. So another 6 to 7 millimeter of correction on the tibia. So that's how I divided his 14 degree varus. Coming back to his clinical presentation, this is how he looks. So that's the varus thrust. This is a patient who is having an interesting finding on the X-ray. He has an exostosis, because of which he was suffering from significant medial compartment pain. He's hardly 42 or 43 years of age. He was suffering for quite a few years, and he is a manual laborer kind of a person. He's working in the Indian Railways. That's his mechanical axis. That's the normal side, and that's the affected side. Those are the angles. That's the medial compartment wear. That's the plan. So the first thing in the surgical technique now is that the patient is under tourniquet. The C-arm is coming from the opposite side. We do the lateral distal femoral osteotomy first, the lateral incision, emphasize the fascia, identify the vastus lateralis, elevate it from the intermuscular septum, place a radiolucent retractor. So you do your dissection under the distal femur, place a radiolucent retractor. So Arthrex has got a wonderful radiolucent retractor which goes all the way on the medial side. You then place the plate. So typically for a closing wedge osteotomy, you have to use the medial plate of the opposite side. So for example, this is the medial plate of the right side, which is being used on the left side. You place it there, plan your osteotomy level with your cautery, place your guide wire, that is going to be the distal guide wire point, place the guide wire. We need to understand that the angle is not parallel to the joint line. So the spinal needle is actually at the part of the joint line. If you want to have an isosceles triangle such that when you close the gap, there is no step off, then you need to create an obliquity. The hinge point is just above the medial femoral condyle, and you need to stop about 5 millimeters short of the medial cortex. So these are the points you need to remember when you pass this guide wire. Arthrex has got a very nice offset guide which helps you to place a second guide wire exactly parallel to this guide wire. And then I place a cut ruler to that 6 to 7 mm mark. You need to account for another millimeter for your saw blade. So if you're planning about 6 mm correction, go to the 7 mm because your saw blade is about a millimeter in width. And then you place a second wire in an oblique fashion such that it meets much before the hinge point. That is the take-home message. So the two guide wires have been placed proximally and distally. Then you measure the guide wires, and then you need to measure the measurement from these for the saw blade, because you need to stop your saw blade about a few millimeters short of the hinge point. So in this case, I'm going to be going up to the 55 millimeter point, and that has been marked. You can cut the guide wires so that your assistant doesn't have to really bend those wires. You can place a finger at the point where you know you're going to stop. So at the 55 millimeter point, you can place your finger, or you can do a good marking. Continuously irrigate the during the sawing process so that there's no thermal necrosis. So you do the distal saw first, measure the planned wedge again, and then take the proximal cut. Having taken this cut, so that's the wedge which is being created. So the chisels are being used now to weaken the wedge. You can also use a 2.4 mm guide wire to weaken the hinge, because only then you can take a nice wedge of bone. So you can see a chisel being used to weaken the hinge point and make the wedge pliable. So the wedge is getting pliable, and once you do that, you're able to take out a nice wedge of bone. This wedge will be used to close the gap in the medial opening wedge osteotomy. You then need to create a biplanar osteotomy, so your ascending cut is being created. This is created at the upper anterior 1/4 level. You go through and through with your chisel then, such that you create a tongue-shaped ascending osteotomy. So the wedge has been taken and tongue-shaped ascending osteotomy has been taken. This is helpful because you create a broader healing area. If you go through and through and if you break a hinge with the entire construct getting unstable with the pull of the gastroc, it can become a nightmare. Even if you break the hinge and if you've done a biplane, you can actually stabilize it extremely well. So you then close the gap. Do not do any forceful maneuvers when you close the gap, very gentle maneuvers. You actually can place a hinge pin now onto the opposite cortex, which actually protects your hinge point, and then you close the wedge. Place the plate then once you've closed the wedge, fix it distally, fix it provisionally proximally too, and then go ahead with your fixation. So the distal locking screws are placed, and then the golden screw is placed in the proximal combi hole to compress the construct, and that is how it looks. So the minute you do the distal femoral closing wedge, lateral closing wedge osteotomy, the mechanical axis, as you see, has come into the inside the joint. You then go ahead with your traditional medial opening wedge osteotomy, and you can get it to the planned 50 or 55% point. In this case, I've used the peak power plate, and this is the post-operative. Here you can see the exostosis in the distal femur, which is probably responsible for the deformity in the femur in this gentleman at such a young age. This is his 3-month follow-up. So the alignment looks excellent. The healing happens very rapidly because in the femur you've got a closing wedge, and on the tibia you actually put the graft there. So the healing is extremely good. The range of motion is excellent. This is his final follow-up where we see excellent healing of both the femur and the tibia and excellent outcomes. A patient who was debilitated and suffering from medial compartment pain is now absolutely relieved with excellent alignment, no thrust. And as I said, he was working in the Indian Railways. So it's very gratifying to see that they are able to carry on with heavy workload also after having been completely compromised in their lifestyles. So that's his alignment post-op, and you can see that the angles have been perfectly matched to the normal levels. So my take-home message, whenever you see that the mechanical axis is medial to the joint line or at the inner edge, think double level. Miniachi technique will not help you to divide the deformity between the femur and the tibia such that the angles fall into the normal range. Understand the principles of not changing the joint line obliquity or maintaining it, and trying to understand that the JLCA should not be altered significantly. Do your lateral closing wedge osteotomy first. Typically, it's in the range of 7 to 9 millimeters, and a medial opening wedge high tibial osteotomy in a titrated fashion next, wherein the correction is usually around 10 to 11 millimeters. Thank you.